Hi, I'm David Levine. I'm here with Dr. John Moore, I believe for the fourth time. Dr. Moore is professor of microbiology and immunology at Weill Cornell Medicine. He's an expert on vaccine research. And he's going to talk to us tonight about the Delta variant and booster shots. So, Dr. Moore, I want to thank you for joining us. I also want to thank everyone who is participating. If you have questions for Dr. Moore, please put them in the Q&A box and we will get to them. And so, Dr. Moore, why don't you give us an overview of the state of the coronavirus right now?
Depends where you live. Here in New York City, life is still fairly normal by pandemic standards.
Okay.
And infection rates are relatively low compared to most of America. There's a above average rate of vaccination. So we're not at the moment in a state of pandemic crisis. But if you're living in Florida, Louisiana, other parts of the South, you're in a mess. And you're in a mess for three reasons, and they're all interrelated. They've got governors who are not taking the pandemic seriously, in the case of Florida and Texas in particular. You have a low vaccination rate, which is still lingering in the 30s and 40% in many counties and lower in some counties. You've got people refusing to wear masks and behave social distancing and so forth. And you have the Delta variant, which doesn't respect any of these political and non-scientific issues and simply will go around infecting you if it can. So, there's probably 100 to 200,000 people walking around the southern states right now who are going to be dead by Christmas. It's really that straightforward. And they'll all be unvaccinated, almost all of them, because vaccination continues to provide very solid protection against the most serious consequences of COVID, including Delta. Delta is not killing vaccinated people with very rare exceptions. They're not finishing up in the ICU. There are more infections than we've been used to, but they're all in vaccinated people, but they're all at home level, mild COVID cases. So the vaccines are keeping people alive, which is what they were supposed to do. And it's what they've been doing consistently throughout. So your current experience and for the next few months depends on where you live and then whether you're vaccinated or not. And if you're vaccinated, you're really not at much risk of having severe illness. And so to the extent that is possible in the context of a pandemic, our lives are reasonably normal, certainly in New York City.
So a friend of mine said she's afraid to visit New York City because she said the rates are sky high. And I agree that compared to probably 2 months ago, they're a lot higher.
Well, it depends. Yes, compared to 2 months ago, everywhere in the country was high. But if you look at the CDC maps and New York Times website, CNN, all the websites that track infection rates, New York and the Northeast are in a green or greenish colored zone. If you look at the South, it's bright, reddy, purple, black for very high infection rates. So I wouldn't see New York City as being a cesspit of COVID that people should be shunning at the moment. Where is your friend living? It's all relative, isn't it?
In Maryland.
Well, Maryland is not going to be very different from New York City, to be honest. The Northeast in general at the moment is low infection, high vaccination, and more often than not, sensible people wearing masks. Not always, of course, but people seem to be more sensible in the Northeast than in the South at the moment.
So I have a few questions. Then I'm going to get to all the other people's questions. Israel is giving booster shots to people over 60. France and other countries are considering it are starting to give it to people who are immunocompromised. Should we be doing the same?
For the immunocompromised and over 70s as soon as possible, because it's justified by their status. the immunocompromised in particular. Not everyone who's immunocompromised is going to benefit from a third shot. Let's be clear about this. There are some people whose immunosuppressive drug therapies for transplants and cancer, or their innate incompetence, you're not going to overcome that with a third shot. But there's also good reasons to believe that many will benefit, and they should receive a third shot as soon as possible. And we're all waiting for the CDC and FDA to act. There's a meeting on Friday at which we hope that that permission will be granted. Over 70s would be the next highest priority, just as they were in the first rollout. The first rollout was done on categories based on perceived need, and that's how any further immunizations would be dealt with.
So I know people who are jumping the line already.
We'll know that.
So that's normal.
Well, you know, I had an interview this afternoon with NPR Radio in San Francisco, which announced earlier this week that they were going to screw the CDC. We're San Francisco. We're going to give second J&J, or we're going to give second immunizations to J&J people,
Right.
which is contrary to any recommendation. And there was a discussion with a emergency room head of emergency medicine or some guy at a hospital in San Fran about whether that's appropriate. And he kept on saying, it's not my decision, but it's okay. You know, and going, okay, well, of course it wasn't your decision, but you have this, weird situation in the States. There's half the population, almost literally half the population, saying, I won't get any vaccine ever in the history of the world, keep away. And there's a very substantial number of people who say, give me as many doses as possible, as soon as possible. I'll have one tomorrow and another in the next week. And then what have you got after that? I mean, I'm obviously exaggerating to make a point, but, the whole basis of public confidence in the vaccines, especially under emergency use authorization, was clinical trial data that proved safety and efficacy that the FDA could review and authorize. And, if we go now, well, we don't really care about getting any more information. We're just going to do this anyway and keep our fingers crossed and hope nothing goes wrong. That's fine if nothing goes wrong. But if something does go wrong and you're in fairly uncharted territory, the public backlash is going to be really fierce, because they'll say, well, the vaccines are now legitimately causing serious problems to many people. So that's the risk. It's not just bureaucracy for the sake of it. And then you get to the medical need issue, this notion that immunity is waning and everybody's incredibly vulnerable all of a sudden. It's just not true. The two-dose immunity for people who got immunized in January, when most people started to get their shots, isn't disappearing like that. I mean, vaccine efficacy tracking is pretty solid. I mean, the Mrna data went down from, I think it was 95% to 93% at 6 months. Well, that's nothing. And Pfizer, there's, the number went down to what, I think 85% or something like that. And there's some questions as to whether that might be a bit of a, a statistical outlier. There's wide confidence intervals. But, 85% for, again, prevention of mostly minor illness, remember, 85% is actually higher than J&J was approved at by the CDC. So, J&J at 75% or thereabouts was viewed as a major triumph, go get it. And people are interpreting 85%, if that's true, as reasons to panic. I mean, there's a lot of worried well people around, and, you understand that, but there's not a whiff of panic in the air, or there shouldn't be. These vaccines are still working, even against Delta, at what they're supposed to do. They're keeping people out of the ICU and out of the morgue, which is kind of where you want to be, or not want to be in the case of those locations. And, if the worst happens and you're vaccinated and you have a mild case of COVID at home for a few days, it's not the end of the world. It's not ideal. Nobody wants that, but it's not really a marker of failures of vaccines.
Will that boost your immunity, having a mild dose of COVID?
Probably. It would act as a booster in its own right, because it's viral antigen. And there's plenty of evidence in when the vaccines were rolled out to people who'd recovered convalescent COVID, people who had COVID last year and got a vaccine shot. The first dose is the charm. I mean, it rams antibody titers through the roof within days. And the second dose doesn't add a lot because it's the first dose is your booster. So it's the first dose in a convalescent is equivalent of the second dose in a naive person. So, nobody's saying you shouldn't go and get both your doses if you're convalescent, but it's the first dose that's the more important of the two.
And also the World Health Organization had said that we shouldn't be giving booster shots to people until we have the whole world vaccinated.
Yeah, that's a very nice and idealistic perspective, and I completely agree with it in theory. But in terms of American politics, it's going to be difficult to apply. But any vaccines that we do not need, and there are announcements today or yesterday about another batch of AstraZeneca going to Mexico or somewhere else in South America, and that's absolutely fine. But there's going to be awful lashback just because they can from the right about giving vaccines away if there's evidence that Americans need them. But at the moment, we have a vaccine surplus. So, but as well as immunizing the rest of the world, the priority is to get dose 1 and 2 into more and more people who have been refusing vaccines. And, there are two categories of people who are refusing vaccines. There's the vaccine hesitant, who need their hands holding and need talking to and persuading, and different people have different reasons, and some are waiting for the official FDA approval, which to professionals is a bit of a nonsense, but you kind of understand where they're coming from. And then there's the vaccine resistant, who are just not going to do this ever, and they're going to die of COVID, calling it lung cancer, because that's their mindset. I mean, there was something in the New York Times last Friday that sent me a combination of ballistic and laughing. That a woman was interviewed and said she's not going to get the vaccine because it will turn you into a zombie, because she saw it on I Am Legend, which is in fact a Hollywood movie. And in that Hollywood movie, it wasn't actually a vaccine that turned people into zombies. It was a gene therapy for cancer. So not only was she not remembering the movie right, she was forgetting that it was a movie. And just because you see something happen on a Hollywood screen doesn't mean it's going to happen in real life. But when you get to that level of mindset, you can't persuade people that they're wrong. I mean, that's just a lost cause. But persuading the hesitant and talking to them is an important priority, and it's still got to happen.
Okay. Now, the other thing is that people have said these drugs are not approved. So, and others have said that full drug approval will get more people to get the vaccine.
I mean, because some people are hung up on this, and there's a ton of safety data. There was a ton of safety data and efficacy data when the vaccines got the EUA, and that was entirely appropriate because we were in fact in a pandemic and people were dying, and we needed to get something approved. And that's not normal, but there's a reason it's called emergency, because we were in an emergency. And data are continuing to be accumulated. They've been filed to the FDA. My understanding is there's 100,000 pages to read through, which take a few of us a few days to get through that if we were in the FDA. So when you accumulate a lot of data, it needs a lot of review, and FDA is being criticized for not moving quickly, which to some extent is true, but the FDA lost a lot of staff last year because they just were hollowed out under Trump. So many people just got so fed up with the environment, they just upped and ran and took jobs in the private sector, and they ain't coming back. So FDA is short-staffed. It has a lot of information to review, so it takes time. I'm sure the full approvals will be given, and to some people, that seems like it will make a difference. And to employers who are considering mandates, that also seems to be making a difference. Although other institutions, including our hospital here, have said you don't need the legal approval or the legal cover of a full approval, you can introduce a mandate anyway. Nonetheless, rightly or wrongly, the full approval thing is a thing. And it will be a thing that won't be a thing in the fairly near future for Pfizer, and followed soon after by Mrna.
So once it's fully approved, my doctor could write me a prescription to get the Pfizer vaccine?
At the moment, no. A doctor can't write a prescription under an EUA. I mean, I have clinician colleagues here who are very, very eager to get another dose of vaccine into some of their cancer patients, and they're being prevented from doing so. And I think that's actually very unfortunate. That is a bureaucratic obstacle in a genuine medical need, but they can't just write a prescription.
But with full FDA,
Full approval, yeah. See, full approval means that physicians can do things like off-label, which includes prescriptions. So they can then do that. But the full approval will probably include this issue. I mean, it's not like the FDA is not aware of this. It will be part of it. And the FDA may decide that they're going to authorize this vaccine or vaccines as a 3-dose immunization regimen. And it may be something like 3 months, 6 months, or 2 months, 9 months. They'll look at the information. That may be what they decide to do. And people will be allowed to vary from that.
All right, so we got a lot of questions, so let's get to them. And I'm jumping the line for a friend of mine because she said she's in a car driving somewhere and she has to be there by 7:30. So I said, okay, so I am 64 years old, fully vaccinated with the Pfizer vaccine. I have no underlying conditions. I'm flying to Santa Fe on August 22nd, scheduled to return back to New York on August 27th. Do you think that's a wise and safe thing to do? And would you take the same trip?
So I was actually looking for the written question and didn't see it. So you might have to just run me through the scenario.
Okay, so
she's got 2 immunizations.
Fully immunized, no underlying conditions, flying to Santa Fe, New Mexico on August 22nd, returning back on August 27th. So is that safe?
Well, nothing is perfectly safe, and I don't know what the stats are in New Mexico, but it's a blue state with a fairly educated population. So they're probably going to have mask wearing and appropriate restrictions. You just behave with common sense. And, you know, you're strongly protected from severe COVID and death. And that's whether you're in New York or in New Mexico. Doesn't matter where you are. I wouldn't go into a crowded bar without a mask on in New York City at the moment, let alone, I mean, New Mexico is probably a little different in the major cities and Albuquerque and so on. So yeah, go enjoy yourself, but just behave with the common sense that I'm sure you would, because you're a mature person and you're not going to do anything reckless.
So next week, New York City is going to, or August 21st, New York City is going to have a concert with Bruce Springsteen, Simon and Garfunkel, all these people. I think 50,000 people fully vaccinated.
Mm-hmm.
Is that a safe thing to do, to attend?
If I like Bruce Springsteen, I'd probably go. It's in Central Park, right?
Central Park, Great Lawn.
Well, I'd rather go there than the Sturgis motorbike rally.
Okay.
Yeah, I think so. I mean, again, it's a relatively low transmission rate and a high vaccine audience, and your risks are fairly minor. I mean, but again, people's tolerance and acceptance of risk is very different. And, you know, I'm pretty tolerant of risk with common sense applied. You know, you don't do stupid stuff, but you can't live in in your basement in a box for the entire pandemic. But different people have different attitudes to this. So it really depends on your own comfort zone. There is not zero risk in going to that concert, but I wouldn't say it was high either.
I played tennis indoors today, and someone said, "Why indoors?" I said, "It's very hot out."
Yeah, I mean,
what are you going to do?
You know, again, you're vaccinated. You're not, even if you contracted the Delta variant, nothing really bad is going to happen to you if you have normal health. I mean, if you're, and again, an immunosuppressed individual, or if you're 75, 80 years old, and something, that's again a risk, an additional risk factor. But for healthy adults who are fully vaccinated, you're almost certainly not going to have a serious outcome to any infection you may or may not get.
So next question. I had my first shot of Mrna on February 25th.
Mm-hmm.
In New York City. My second shot was scheduled for March 25th, but I had a family emergency. And I was in South America from March 13th to August 4th. I got my second shot until August 7th. Given the lag time between the shots, should I get another shot of Mrna in a month?
Well, you can't at the moment because we just went over that. I don't see an issue with that at all. I mean, the Brits did what we in the States thought was quite funky and didn't really approve of having a very long dosing interval between dose 1 and dose 2. We had, what, 3 and 4 weeks for Pfizer and Mrna. The Brits extended it in some cases to 3 months, and didn't seem to be any problems. And there are some studies showing that a long delay actually gives you a slightly better immune response after the second dose. Of course, the downside is for 3 months, you've only had 1 dose and are therefore not fully protected. So I'm not recommending people go to 3 or 4 months, but I would say get the second dose, tomorrow, and you'll be fine. In fact, you would then be so fully protected, you wouldn't even think about another dose in a month's time. I mean, you'd be in the sweet spot.
He got his second dose. He just spent time getting it.
Yeah, but if you have a long gap, it's really not a problem.
Okay. So again, please put the questions in the Q&A box, not the chat box. So someone said, what is causing the COVID virus to mutate? The measles virus is not mutated. The vaccine has been working fine. And the polio virus infections have been virtually wiped out with the polio vaccine. So why not the COVID virus infections?
Different virus, different properties is the simple answer. The coronaviruses are RNA viruses like influenza and like HIV. And all RNA viruses mutate. And they mutate at different rates. And we're somewhat fortunate with coronavirus as its mutation rate is far, far less, but it's less than influenza and it's far, far less than HIV. So to a HIV guy like me, coronavirus is actually a fixed target, I mean, in relative terms. But if you give an RNA virus, a few 100 million people now worldwide and give it 18 months, that's a lot of replication cycle. And it's a numbers game. So the more you replicate, the more you mutate, and large number of people, long period of time, you're going to get variants. And we've seen this consistently from within a month of the first wave of the pandemic. We saw the first variant arise it's called D614G. It arose in Europe in April, probably in a ski resort of 2020. And by about September, it dominated the global pandemic. It replaced the original Wuhan strain. And then the Alpha variant arose in the UK in September, October of 2020. And that then became the dominant global strain. I mean, that was responsible for the January, February surge. Delta, when it arose in India, has an advantage over Alpha and has replaced Alpha as the global strain. I mean, it's all about replication efficiency. The more spreadable you are, you outcompete the less capable variants. It's a Darwinian survival of the fittest. So Delta is currently the most transmissible variant we've ever seen. There are other variants around that are troubling because they're more antibody resistant, but they don't seem to have Delta's spreadability.
Okay. So how long is the 2-shot Pfizer vaccine effective in people over 65?
Probably about as long as someone under 65. I mean, there's variation between people here, right. But in the phase 3 trials and other trials, immunogenicity was looked at by age: younger people, middle-aged people, older people, and really old people. I mean, and immunogenicity starts to diminish in the over 80s. Again, it will vary between people, but over 65 isn't really a big deal for loss of immunity in most healthy people. Over 80, you start to see some diminution of performance, which is why older people should be prioritized over younger ones for any third dose.
So if a fully vaccinated person is infected with the Delta variant, what is the likelihood of having long COVID symptoms? 2 people asked that question.
Yeah, and it's an unknowable. It's literally unknowable because there hasn't been time to see it. I mean, long COVID by definition is something that takes place over a long time. And so you can only know that after a long time. I mean, I hate to sound facile, but that's what it is. Best guess is probably no different than a mild infection in an unvaccinated person. I mean, most cases of long COVID have been in people who are quite sick to start with. So mild infections are generally not associated with long COVID, and vaccinated people are getting mild infections. So, you know, I'm putting 2 and 2 together and hope I'm getting 4, but really the answer is unknowable at this stage.
So a hospital in San Francisco is offering people who receive 1 dose of the J&J vaccine a second dose of either Moderna or Pfizer. What are your thoughts on the potential benefits and risks of getting an mRNA booster after the Johnson & Johnson vaccine?
Well, I mean, again, I sort of touched on this earlier. I mean, there is literally no data anywhere in the world that I know of J&J followed by Moderna or Pfizer. So it's an unknown. And the question is, do we want to approve or use vaccines based on not knowing anything, or do we want to do it based on knowing as much as possible? And J&J was, you know, in my mind, it has always been a 2-dose vaccine. And you can argue why it was approved at 1 dose. It was approved at 1 dose, which has some conveniences. And, you know, I'd love to know exactly who was responsible for that decision. But I think it's a 2-dose vaccine. And J&J have had a 2-dose phase 3 trial ongoing in the USA that started last November. So it's almost, it's 9-10 months out, and it still hasn't reported. And it's supposed to be it's like one of those, you know, waiting for Godot things. It's going to happen next week. It's going to happen the week after. Every week it's, you know, so they haven't reported on that. But the immunogenicity data and the animal data that we've seen from 2-dose J&J is it's a superior regimen to 1 dose. And the Russian Sputnik and the AstraZeneca vaccines are both similar design, and they were approved and used as 2-dose right from the start. So I think a better strategy for J&J people is to get a second J&J dose when FDA has access to and approves and reviews the ongoing data, because at least it'll be data driven. But, you know, San Francisco is doing what San Francisco is doing. I don't think that's going to be that widespread. And again, J&J, if you take J&J, you're not going to finish up in the emergency room, ICU and the mortuary. It's not as effective against mild COVID as 2 doses of the mRNAs, but it is not useless at keeping you alive.
Okay. So here's someone who I think knows you. I don't know who. In addition, okay. We are both in the Novavax trial at the Weill Cornell site. Despite the press releases from Novavax that the vaccine is extremely effective and safe, they're now delaying in the US filing once again for at least 3 months, leaving US trial participants in limbo with no acceptable proof of vaccination other than the CDC card that says trial participants. So what are you going to do now? Are you planning to get an EUA vaccination? If so, which one?
Well, I also was in the Novavax trial, and I know a number of people who were.
Okay.
It is a very effective vaccine. It was 90+% in phase 3 in the UK and our USA trial. So I have no concerns about my vaccination status. It's all about the freaking paperwork. So we have cards from the CDC attesting to our fully vaccinated status. Those cards are not being accepted by international travel authorities, like, you know, countries that require you to have a vaccine card to get into the country, or cruise liners, or, you know, other forms of travel. And that reason is because Novavax is not on the WHO approved vaccine list, although a pretty crappy Chinese vaccine is, because it went through an EUA in Europe. So it's a bureaucracy issue. Then we all know that there's going to be this New York City pass in the near future. I have been told on the grapevine by someone who knows someone that Novavax and AstraZeneca trial participants are going to be included in the New York pass system at a recognition of the fact that they are vaccinated. I'm kind of going to believe it when I see it, but I think it will happen. I think New York City had enough lobbying from the medical schools, because there was an AstraZeneca trial at NYU, and AstraZeneca is not approved in the USA. So, there's two populations of clinical trial specialists and their patients who are saying, do something about this. And I think it will happen in New York, but internationally, I don't know.
So next week in New York City, you're going to have a proof of vaccination or maybe a negative PCR test to go to a gym, do indoor dining, to go to indoor entertainment.
Yeah.
So you won't have that, I guess.
Well, that's what I'm saying. I have a pass with a CDC logo on it, and it says I'm fully vaccinated. So if I were going to a place where I needed to show it, I would show it, and I would hope that they would accept it. But, it would be an interesting test case. It won't be the gym. I kind of delegate that to younger people.
Okay. So do you believe indoor dining or gyms are more dangerous now because of the Delta variant?
Again, not if you're vaccinated. I mean, yes, everything is more dangerous than it was. I'm not diminishing Delta's capacity to infect people. This is a nasty variant that is causing enormous problems, but mostly for the unvaccinated. So if I was not vaccinated, I would be very concerned about going to high people density places. On the other hand, if I wasn't vaccinated, I'd probably be, I probably would be doing stupid things anyway. I mean, it's kind of goes with the territory. I mean, I wouldn't be wearing a mask and I'd be going to Sturgis motorbike event.
Okay, so I want to talk about children, and then because we have a few questions about children, and I have children and grandchildren. So are children under 12 who can't be vaccinated at more risk from Delta than they were at earlier variants?
Yeah, and this is another issue where FDA really needs to move as fast as is humanly possible, because we need these vaccines approved for use in younger children. COVID is still rare. Delta-induced disease is still rare in children, but it's more common than it was. And New York Times have had a couple of pretty good articles the last 2 days on infected children with, significant symptoms. And in some cases, children would get long COVID, they have real serious issues. So it's not that children are invulnerable to COVID, they never have been. It's all relative risk. They're less at risk than older people, but they're not at zero risk. And Delta increases that risk. So absolutely kids should be wearing masks at school, and so should teachers. And I favor mandating vaccines for teachers because they're the same, in my eyes, are the same as healthcare workers. And their primary loyalty is to their children, their pupils, or their patients if they're healthcare workers. And whatever personal scruples you have, it goes with the job. You have to do what is necessary for the children in your care or the patients in your care. So, the teachers' unions seem to be pushing back against mandates. I have several teacher friends, and they're all appalled by this. They are vaccinated, and they want all their colleagues to be, and they want to be able to protect their children in the schools because they care about the kids. And the kids, unfortunately, are going to have to wear masks, and I think it'll be mandatory in New York City. And it's right, because they are not at zero risk, and Delta increases that risk. So it just makes sense to my mind.
So how likely is that even a mild case in a vaccinated individual who may have a comorbidity such as diabetes can lead to eventual future morbidities?
Well, again, people with comorbidities are always going to be more at risk of infection in any circumstances. That's been true right throughout. So even if you're vaccinated and you get infected, you have to again assess your own personal relative risk and factor that into your decision. I mean, if your risk is going to be much, much less after vaccination, but I don't think anyone can quantify it. And you've got to know your own status and behave accordingly, but it would be lot less risk than if you weren't vaccinated.
Are preparations underway to improve existing vaccines in order to make them effective against new variants that defeat currently available vaccines? Now, let me just ask a question. So I told my friend who rushed to get the third dose of Mrna vaccine, lying, of course, and saying he hadn't been vaccinated. I said, well, what if they come out in October with a new Mrna vaccine, which is, supposedly more effective? Then what?
Well, for, I don't know, 6 months now, there have been tests certainly for Moderna, Pfizer, and Novavax, well, a moot point for them, of a variant-based vaccine. And that vaccine is essentially the same, but it's based on the beta strain that arose in South Africa. And that is the most antibody-resistant variant that we've seen. So Delta is the most transmissible, but Beta is the most antibody resistant. And so it made sense to make a Beta design vaccine. However, Beta hardly exists in the States now. It's been squelched out by Delta. So there's not a lot of Beta around. I have not seen data on whether anti-sera to the Beta vaccine would do well against Delta. I think it would, because Delta is not that antibody resistant. Delta is sort of half, Alpha is not antibody resistant. Beta is very resistant. Delta's in between. So, if the Beta vaccine were rolled out, it would probably work just as well against Delta. It may not work any better than the one we've got. So, again, there was a gamble, if you calculated decision taken in January or February when Beta started to circulate in some countries, notably South Africa, to make a Beta variant vaccine in case Beta spread here, but it didn't. So, and in some ways we got lucky with that, but we got unlucky with Delta. It's, damned if you are and damned if you don't. But making a Delta variant vaccine is possible, but again, it would take multiple months, and it just may not be necessary because Delta is neutralized. The Delta variant is neutralized pretty well by 2-dose Pfizer and Moderna sera.
Here's a question. What do we know about breakthrough infections in vaccinated pregnant women? What should they be aware of and precautions to take?
I know almost nothing. I've not seen anything on this, probably because it's still very rare and there hasn't been enough information accumulated to be put into any form of preprint or discussion or so forth. Again, in all probability, it would be a very mild infection at worst, because that's what vaccines are doing, and it would no good reason to believe it would be different in a pregnant woman.
Someone asked kind of a lab question for you. Is there any relevance to the existence of animal vectors of COVID-19? And another question was, isn't it true that no pure COVID-19 virus has been isolated?
The first question, that pure COVID virus thing, that's a standard trope that is thrown at virologists, and I'm not even going to go there. It just doesn't, I'm not going to answer that.
Okay.
It's just, a criticism of virology. Is there any relevance to the existence of vectors? That was a thunder clap, by the way, if you want to.
I heard that, yes.
It wasn't that my office has just imploded on me. Animal vectors of COVID-19. Well, COVID came from a crossover event from an animal of some description, most probably a bat, but it's not proven unless you believe the lab leak theory. But even if you believe the lab leak theory, it came from an animal in the first place into the laboratory. So there is an animal vector of COVID-19, just as there was an animal vector of the original SARS and of MERS, the Middle Eastern respiratory virus, which is transmitted from camels. So animal vectors exist, but there's no evidence that crosses over very often. There are a few examples of humans infecting cats, and humans infecting dogs. And there was a bit of a mink scare in Holland and Denmark late last year. So you can get cross-species transmissions, but it's not the top of my radar screen at the moment, thinking when a new COVID variant might cross over from some animal or other. I mean, there's only a limited number of animals that appear susceptible to this family of coronaviruses.
So I'm going to say, can you talk about the value of home COVID tests? I noticed in Walgreens and CVS, you can buy a home COVID test.
Yeah, I've never done it. Well, I've never had a reason to do it. I mean, there are two types of tests. There's, antigen tests that detect the presence of the virus, and there are antibody tests that detect the presence of antibodies to the virus. And they're not the same thing, and people often confuse them. And so you've got to know what you're buying. And then there are different types of antibody tests, and some of them are based on the viral N protein and detect infection having happened in the past, and don't detect the antibody response induced by a vaccine. So I've heard of plenty of people who've bought one of these N protein tests to test whether they have a vaccine-induced antibody response, come up negative, freak out, and then get told, well, you bought the wrong test because it doesn't detect your anti-vaccine antibodies. So you got to know what you're buying and why you're buying it. And then people send me their numbers and say, well, I took this test and I got this number. What does it mean? And I say, I have absolutely no idea, because there's no frame of reference. I don't know what test X by company Y giving a number of 73 actually means. There's no way of judging. So is that a big number or a small number? I just literally don't know. So it's very hard to interpret other than on a yes/no answer.
So I see a lot of people walking around New York City now with KN95 masks, and people are saying you should upgrade your mask now because of the Delta variant. Should we?
I've heard that. I haven't. I just wear the same freebie mask I got in a handout packet at the end of last year from a employee wellness scheme, because it was quite, well fitted and it was free, and I like free things. I don't know. Should I get a new mask? I haven't had a driver to do it. There's nothing wrong with over masking. It is better to over mask than under mask. So if you have access to an N95 and you're comfortable wearing it, it is better to do that than, wrapping a sock around your mouth. I mean, over mask rather than under mask. And I see people with two masks on. Again, totally fine. It's better to over mask than under mask. And if you can get an N95 and it works for you, it is certainly superior quality. But remember, these variants don't have little pairs of scissors. They don't cut through masks. I mean, a layer of cloth or a double layer in most of these is sufficient to stop viruses getting through. If they're going to get through, they're going to get over or round. You're going to not have it on your nose when you should do. And we know we all need to, and we don't always have it on our noses. So it's more likely to get round the mask than through the mask. But yeah, look, the bottom line is over mask is better than under mask.
Are reliable tests for neutralizing antibodies available? Are there accepted thresholds for determining relative risk or successful vaccinations similar to what is measured after hepatitis B vaccination?
Well, the reliable tests are available, but only in specialist research laboratories. I mean, my lab does a neutralizing antibody test, but we don't do it for the public. And in fact, we're not legally allowed to do it for the public, and we wouldn't do it for the public. And there isn't really one that you can buy over the counter. There are sort of pseudo or surrogate assays, and for all I know, some of them are on the market. I don't track what's on the market that the public can buy, but they're pretty specialist assays. And there's increasing papers out now looking at protective levels, again, done in laboratories, of surrogate assays that are easier than virus neutralization, and we're getting a handle on those. But again, relating it to the over-the-counter tests that are, you never know what company's done them, and it's just a bit of a zoo. I wouldn't be relying on anything like that. It's, ideally you would like to have access to something that is truly reliable, absolutely validated, gives you a number and you can make a judgment. But even then, people, without training and specialist knowledge might over and misinterpret the numbers. It's not an easy thing to do.
So I look at Europe and see that they're now actually exceeding us in vaccine numbers, which is good because they're way behind. But they're also starting to mandate. I think Italy has a green pass, so you can go into a restaurant or go to entertainment. France is getting very, very strict and saying that, if you want to go to a restaurant, if you want to go on transportation, what do you think of that?
I was opposed to mandates a year ago, and philosophically, in part, because of my own psyche about these things, I'm increasingly in favor of it because there's just no alternative in many cases. Whether it's an actual mandate that says you must have a vaccine, or whether you create a situation in which it is really inconvenient not to be vaccinated, which is another form of mandate. These are the things you cannot do unless you get a vaccine. So you're driving people to make a choice between some kind of pseudo-philosophical position, anti-vaccine, or having an inconvenient social life. I think what would change a lot is if the domestic airlines made vaccination mandatory for getting on a flight. I don't think they will, but I think that would be huge as a driver. But more and more employers are doing it, and more employers will do it after the full approval, which we discussed earlier, and is in part related to, some schools of lawyers say you need that full approval. Other schools of lawyers say, no, you don't. So some companies are just going with we'll wait for the full approval and then they'll come the hammer down. But you're hearing it more and more. And, look, this is now a pandemic of the unvaccinated. I mean, that's just a simple statement of fact. I mean, it's an overwhelming proportion of infections are in the 50% of people who are not vaccinated. So they're keeping the pandemic going. And the longer the pandemic goes, the more variants will arise. And there are worse variants we can imagine, or certainly there are worse variants possible. They're also compromising economic recovery. And, the Republicans all about economic recovery, profits, business, et cetera, but they won't do what is necessary to have a full economic recovery, which is to eliminate this virus. And you won't eliminate this virus without vaccination. So there's this weird illogicality to it all. So finding whatever ways it takes to increase vaccine uptake in America is the only way we're ever going to get rid of this virus, and the only way we're going to prevent new variants emerging. So, it all sounds very draconian, but what's the alternative? Just go on like this indefinitely?
Should schools be requiring vaccinations for students above the age of 12? I mean, some colleges are requiring vaccinations. Yeah,
colleges are requiring vaccinations for students. Absolutely, they are. Now there's an increased industry of fake vaccine passes along the same logic as fake ID cards to get you in a bar. So there's always people gaming the system, but it's necessary to get. Again, it's community protection. It's people protecting each other and protecting the people they come into contact with. I mean, there were examples last year of outbreaks in college towns that were caused by unvaccinated students, behaving as students do and having parties, and there's nothing wrong with that. But they were infecting local residents, some of whom died because they're not younger people. So there's a responsibility to other people. And vaccines don't just protect yourself, they reduce the chance of you infecting someone you come into contact with that you might literally kill. So, universities have teachers and staff who are old in some cases, and the students are a risk to them more than to each other. So you're protecting the whole community, not just the individual students. The same applies in schools. Schools have janitors, schools have support staff, schools have custodians, schools have teachers, and children are vulnerable, more so, as I said earlier, more so to Delta than to previous variants. So protecting them and each other and then when they go home, their grandparents, it is all makes sense. So yeah, I'm fully in favor of it.
So, okay, we have a lot of questions from parents. Okay, vaccinations do not prevent the risk of infection and spreading the virus to more vulnerable elderly family members.
Well, I'm going to push back on that. They do. Vaccination does prevent the risk of infection very, very substantially. That's proven. Now, and the protection against any form of infection, judged by PCR tests and whatever, for Pfizer and Moderna is again in the 80s to 90% range. So it does strongly protect against infection. And Delta, there are concerns that Delta is allowing more infections. And there are examples of Delta infected people spreading the virus to other vaccinated people. So Delta is, again, different and worse, but it's not like the sky's falling. These are still relatively rare events, but I know of several households through social personal contacts where an infected person, a fully vaccinated person, got Delta infected and transmit the infection to other people in that household. But they all had mild COVID at home because the vaccine stopped them getting any worse. So, would you advise against a couple of 2-hour flights to visit grandparents abroad? Are the grandparents vaccinated? If the grandparents are vaccinated in their healthcare systems, your risk to them to causing anything serious is again minor. But you've got to factor that in. You've got to, take into account, what do you know about your grandparents? What do you know about yourself? There's no blanket, easy answers to this. You've got to just, treat every moving part in this, every individual, you've got to treat with, appropriate consideration and decide whether your desire to see your grandparents is outweighed by what you assess to be the risk.
Okay, so I have a friend who asked this question. She had COVID. She had both Moderna vaccines, and she's concerned about overstimulating the immune system with a booster shot. So would she need a booster shot?
She had what, 2?
She had COVID.
She had COVID, and what she had since?
And she's fully vaccinated.
Then she doesn't really need anything else. That's 3 doses of viral antigen. So she's had effectively her 3rd dose for all practical purposes. And again, as I said earlier, for recovered patients, convalescent patients, the 1st dose of Moderna and Pfizer is the charm. The 2nd dose doesn't add a lot. So I wouldn't be thinking about getting essentially a 4th dose. I don't think that's necessary.
Okay, and this is from cousin of mine. He's saying, where do you think we will be 2 years from now? I know you're not a prophet. Do you think COVID will ever fully disappear?
Well, ever is a long time. So yeah, at some point it will fade into insignificance because most people will have been vaccinated or infected by it. Over time, there's generally a driver for, viruses to become endemic, and like the common cold coronaviruses, but that takes decades. What the future trajectory is depends a lot on the vaccination rate. And remember, the rest of the world is nowhere near vaccinated. So there will always be increasing circulation until the planet is vaccinated. And you can't build a wall and keep out respiratory viruses indefinitely. So it's in America's interest to help vaccinate the world to reduce and eliminate the spread. But, the 1918 influenza, everybody's read, 1918, it actually didn't end until 1921. It, became 1919 was the worst year of the 1918 pandemic. So, yeah, this is going to be around for a while yet. But the trajectory depends on what percentage of Americans eventually get vaccinated.
So Francis Collins was on the talk shows on Sunday, making him want to. I don't see him on that often, and he was saying that what is going on in Florida, what is going on in Texas, it was totally preventable.
Totally what?
Preventable.
Yeah, of course it is. It's political. Yeah. There's a question there, how would I communicate with the governors of Florida and Texas? I would tell them that they're killing their citizens for the sake of their political careers, that pandering to their base because they're running in a primary election next year isn't an appropriate alternative to doing the right thing for public health. And you are killing your people. And it's just irresponsible and reprehensible.
And their popularity is going down.
And so it should. And the irony is the people who they're killing are their base voters who are least likely to have taken the vaccine. So there's an irony in there.
So there are a few more questions. Let's see. Why can't we have vaccines that are good for multiple subtypes? Why does each vaccine only have antigens for one subtype?
Well, when the vaccines were first designed in January of 2020, there was only one subtype. So there was nothing, there were no variants to factor into the vaccine. So that was the simple answer, that it was driven by history. And I discussed earlier how a beta variant vaccine was designed in January of 2021 on an if we need it basis. So you can do it. But again, they need testing, although FDA will approve a variant vaccine very simply on the same basis that it approves a variant flu vaccine every year. So there could be a variant vaccine, but I don't think it's needed against Delta.
Someone says, we have a 5-year-old daughter who never got her second round of vaccines last year. I assume these are the standard childhood vaccines. After she can get her COVID-19 shot, when should she be ready to resume her standard vaccination schedule?
They're independent of each other. She should get her second round of vaccines as soon as possible. I mean, I don't think 5-year-olds are going to be eligible to get a COVID vaccine this year. I can't remember the exact cutoff. I think the next range is 8 to 12, or is it 6 to 12? I haven't seen anything on children that young.
I think it's 6 to 12. They're asking to.
12, so a 5-year-old wouldn't be eligible this year, but she should get her standard round of vaccines as soon as possible, because there are other infections around that she needs protecting against, or he, I can't remember if it's a girl or a boy. So go and get the vaccine. Don't worry about the COVID vaccine at this stage, because you can't get it for her, but she needs the rest of her standard course. Go for it.
So I'm going to close with a question that I get a lot, is that, are you changing your behavior due to the Delta variant?
Have I?
Yes.
Oh.
I mean, should people be changing their behavior because of the Delta variant?
Well, again, it's situational awareness. I haven't changed my behavior because I'm not reckless at the best of times, but I don't live in a box in the basement. So, if New York City has a major surge of Delta along the lines of what's going on in Florida and Arkansas and Louisiana, I would certainly think about how to respond to that. Yeah. But at the moment, we don't have that. We have a low infection rate by national standards. And I'm vaccinated, and I'm confident in the vaccine I took. So, but you've got to look at the situation. You've got to track your surroundings. I mean, and adjust accordingly. I think common sense, there's no substitute for it, and self-awareness.
Okay, well, Dr. Moore, I want to thank you for again spending time with us at Science Writers in New York. We do appreciate it. And
I just want to, this thing, but one can make an argument about being unvaccinated is akin to riding a motorcycle without a helmet. Well, that's only true if you look at yourself. You have the right to kill yourself. No one doubts that you have a right to kill yourself. There are more efficient ways of doing it than getting unvaccinated and contracting COVID. But you also have a responsibility to the people around you. And if you crash your motorbike, well, okay, you could fly like a missile through a car window and kill the car driver, but you're probably really only taking yourself out. With COVID, you're taking other people out around you. And then you're also, putting the healthcare system under stress. You're putting doctors and nurses under stress. Okay, that's also true if you ride a motorbike, but it's not really the right analogy. And, we're living in a complicated society, and you owe it to other people around you to help eliminate this pandemic. It's not just as simple as making a decision, say that's best for me, I choose to be a risk taker, I'm going to drive my motorbike down the FDR at 100 miles an hour. It's not quite like that.
All right, so there is the last question. So, okay. What do you believe to be the best argument to present to someone who is still concerned about the lack of long-term safety data for the current vaccines?
I mean, it's another good and frustrating question, because you can only get truly long-term data over the truly long term. So when people say, how do you know I'm not going to get cancer in 10 years? It's an impossible question, because you don't know with absolute certainty. But you can say there is just no plausible biological mechanism that we can think of whereby that is going to happen. It's not, you know, people say, well, mRNA vaccines get into your DNA and change your DNA. No, they don't. That's another, you know, I Am Legend zombie making myth. It's another something that was created by someone and put out on the internet and became an internet meme. And it's just not true. So no, there is no absolute certainty, but there is a strong certainty that if you don't get vaccinated, you're going to have COVID, and that might be really something you want to avoid. So it's, again, relative risk. No, nothing in life is absolutely safe. If you stay in bed all day, you might die of bed sores. I mean, it's just all relative risk, and the relative risk of dying of COVID is far greater than the risk of something hypothetical about vaccines, you know, in 10 years' time. I'm very confident that I am not going to suffer long-term consequences for being vaccinated. And, you know, it's the same with masks. People say, well, it's really inconvenient to wear a mask. It's really, really inconvenient to wear a ventilator. So I'm told. You don't want a ventilator on your face. Wearing a mask, if it stops you wearing a ventilator, is a very good trade-off.
So I saw the movie I Am Legend. I actually saw it during when I had the flu. And I was saying, maybe this is not the best movie to be watching when you're sick.
Yeah, and you know, if you read, I actually read the book as well. And if you read the book, it didn't even, the zombies weren't even created by a gene therapy cancer virus. It was something, I can't remember what it was, but it was the film extrapolated from the book, and then the internet has extrapolated from the movie. It's just totally bizarre.
So we've gotten several thank yous from the audience. So
you're welcome.
We do appreciate you spending time with us.
Sure.
Next week we're going to be talking about social media's role in Europe, which is very different than the United States. And in Europe, they're actually being used to promote people getting vaccinated, including Rafael Nadal, who made a public service announcement about it, the importance of being vaccinated. So again, Dr. Moore, we really, really appreciate you taking time out of your busy schedule to spend time with us. And I also want to thank Joe Bonner, who's behind the scenes, for doing all these broadcasts. And I'm sure we'll see you soon.
Okay, well, always happy to do it. It's a nice audience, and you guys do good work. Thank you.
Thank you. Take care. Bye-bye. Everyone stay safe and get vaccinated if you haven't.